Welcome to Evidence Mastery with Dr. Masoon Tusi. I am going to help you understand what seizure disorders are and how they are managed. Please note that this video is for education only and will not replace your doctor's advice. Brief pause. So, what exactly is a seizure? Well, at its core, you can think of it as a sudden electrical storm inside the brain. It's this abnormal, unregulated discharge of electricity that temporarily hits the pause button on normal brain function. And that interruption can show up in a whole host of different ways. Now, this is a really important point we need to clear up right away: the difference between a seizure and epilepsy. They're not the same thing. A seizure is a single event, right? It's that one electrical surge. Epilepsy, on the other hand, is a chronic disorder. It means there's an underlying condition that makes a person more likely to have these seizures over and over. So, and this is key, just because someone has one seizure doesn't automatically mean they have epilepsy. Okay, so here's our game plan for this explainer. We'll start by digging a little deeper into what a seizure is. Then we'll look at the causes and how doctors classify them. After that, we'll cover the different signs and types, how seizures are diagnosed, and of course, how they're managed. We'll wrap things up with the prognosis and some key takeaways you'll want to remember. All right, let's dive into our first section: what is a seizure? We're going to take a closer look at the brain's electrical system to really understand what's happening. So, you might be surprised to learn how common this is. The evidence shows that about 2% of all adults will have a seizure at some point. But here's the really crucial part. For 2/3 of those people, it's a one-time thing. They never have another one. And that right there is why a thorough medical evaluation is so important after a first seizure, to figure out if it was an isolated event or something more. Okay, moving on to our second section: causes and classifications. Now that we know what a seizure is, let's explore the why and the how. What can cause them and how we categorize them. What's fascinating is that the typical causes of seizures really change as we go through life. If you look at very young children before age 2, you're often looking at things like high fevers, issues from birth, or metabolic problems. Then, from ages 2 to about 14, it's very common that we actually don't find a specific cause. We call that idiopathic. But once you get into adulthood, the picture changes. We start to see causes like head trauma, alcohol withdrawal, tumors, or strokes. And for older adults, tumors and strokes become even more common triggers. So, to make sure everyone in the medical community is speaking the same language, the International League Against Epilepsy, or ILAE for short, came up with a classification system. It's really a logical step-by-step approach. First, you determine the onset. Where in the brain did it start? Second, you note the person's awareness. Were they aware of what was happening? And third, you identify the features. Did it involve movement, what we call motor symptoms, or not? Let's zoom in on that first step, because it's absolutely critical. We're talking about focal versus generalized onset. A focal seizure starts in a specific network in just one side or one hemisphere of the brain. A generalized seizure, on the other hand, seems to start in both hemispheres at the same time. And trust me, figuring this out is a huge deal. It changes everything about how we diagnose and treat it. All right, on to section 3, signs and seizure types. Now we get into what seizures can actually look and feel like, from subtle signs like auras all the way to convulsions. You've probably heard the term aura before, maybe thinking it's some kind of warning before a seizure. But here's a key clinical insight. The aura is the seizure. It's actually the very beginning of a focal aware seizure. The person is still conscious, but they experience something odd. It could be a strange smell, a sudden wave of fear, or that weird déjà vu feeling. And this experience gives us a huge clue about where in the brain that electrical storm is kicking off. And wow, do seizures come in a lot of different forms. For instance, you have absent seizures. These are really brief periods of lost awareness, where someone might just stare blankly. They're often mistaken for daydreaming, especially in kids. Then you have the one most people picture, the tonic-clonic seizure, which used to be called a grand mal. That's where you see loss of consciousness, body stiffening, and then the convulsions. And as we mentioned, with focal seizures, the big question is whether the person's awareness is maintained or impaired during the event. Okay, this is extremely important. Most seizures are actually pretty short. They stop on their own, usually in less than a couple of minutes. But if a seizure goes on for more than 5 minutes, or if someone has multiple seizures back to back without waking up in between, that's a whole different ballgame. That's a life-threatening medical emergency called status epilepticus. It requires immediate medical help to prevent permanent damage to the brain.
So, how do doctors figure all this out? That brings us to section 4, how seizures are diagnosed. Let's open up the clinician's toolkit.
The diagnostic process is a bit like detective work, and the single most important clue is the story. A detailed history from the patient and anyone who saw what happened is absolutely step one. From there, we build the case. We might run blood tests to check for metabolic issues. We'll use neuroimaging, like a CT scan or an MRI, to look at the brain structure for any abnormalities. And then there's the EEG, which records the brain's electrical activity, listening for any suspicious signals.
But, and this is a big but, it's crucial to know what an EEG can and can't do. It's just a snapshot in time. So if the EEG is done between seizures, it can look perfectly normal. I want to be really clear about this. A normal EEG does not rule out a seizure disorder. At the end of the day, the diagnosis is made clinically, based on the whole picture. All right, let's talk about treatment. Section 5, how seizures are managed. We're going to cover everything from immediate first aid to advanced long-term therapies. Let's start with first aid, because knowing what to do can make a huge difference. If you see someone having a convulsive seizure, stay calm and time it. Your main goals are to keep them safe. Loosen any tight clothing around their neck, and maybe slide something soft under their head. Gently turn them onto their side. This helps keep their airway clear. And 2 big don'ts. Don't ever hold them down, and don't ever put anything in their mouth. Simple, but so important. When it comes to long-term management, there's a whole range of strategies. For most people, the first line of defense is antiseizure medication. Sometimes, if there's a specific cause we can treat, like removing a tumor, that can solve the problem entirely. For those who still have seizures even with medication, what we call refractory epilepsy, we then look at more advanced options. This can include surgery to remove the seizure focus, or even implanting neurostimulation devices. Let's talk about those neurostimulation therapies, because they're pretty amazing. Think of it this way. Vagus nerve stimulation, or VNS, is kind of like a pacemaker for the brain. It sends out regular, gentle electrical pulses to help prevent seizures. Then there's responsive neurostimulation, or RNS. This one is even smarter. It's like an on-demand system. It actually listens for the abnormal brain activity that signals a seizure is about to start, and then it delivers a targeted pulse to stop it in its tracks. And finally, that brings us to our last section, prognosis and key takeaways. What does the future look like for people with seizure disorders? And what are the most important things to remember from all this? So, what can people expect with treatment? Well, this classic study gives us a really good idea. The evidence suggests that for about a third of patients, the right treatment can eliminate seizures completely. Another third will see their seizure frequency cut by more than half. So, when you add that up, it means that for roughly 2/3 of people, we can achieve really significant control, which is a huge deal for their quality of life. So that really leaves us with a powerful question for the future. I hope you enjoyed this video. Please feel free to share your experience or questions in the comments. Please note that I won't answer personal questions. If you found this video helpful, don't forget to subscribe to my channel.